Hello, my name is Petipazi Raimondiol, student of BHMS at AM Kota Kinabalu. Okay, today I will present a case about the patient care and management of a patient with severe traumatic brain injury. It's not TBI. Okay, what is TBI is? TBI is a traumatic brain injury, also known as an intracranial injury, which is an injury to the brain caused by an external force. And the most prevalent cause of it include falls, accidents, assaults, and hit to the head. And according to Nelson et al. 2016, there's 1.5 million TBI in US each year, and it was a leading cause of mortality amongst those under the age of 45 years old. Okay, let's start about the case. Bystander found a 28-year-old man who has lost control of his motorbike and gone off the road, unhelmeted and unconscious. And then called red zone trauma activations, and he was transferred to ED by ambulance and intubated. And assessment finding on site is GCS was 3/15, bilateral fixed pupils of 4 mm, right parietal cephalohematoma and right CSF arteria, and vital signs on site is BP 172/118. Heart rate was 28. After 30 minutes arriving at red zone, BP was 221/105. Also, an atropine pulse as well as nicardipine infusions for hydrations and drug delivery, arterial line and CV central venous catheter were inserted, and intubated was initiated. 30 grams of IV mannitol, a hypertonic solution of 20% weight over volume, sodium chloride, and left side decompressive craniotomy were all used as emergency therapy for herniation syndrome. And this was a CT scan of the head reveal, figure 1 and figure 2. Effacements of the third and fourth ventricle shown at the figure 3 and 4. In at the figure 4, it shows that a left frontal or temporal and parental hemorrhage with mass effect and cerebral edema caused a 5.38 mm left to right midline shift. And during a CT, a frontal skull base fractures and a complicated non-displaced comminuted fractures of the right temporal bone were also discovered. External ventricular drains was implanted post-op and the initial intracranial pressure was 14. The patient was checked both before and after the EVD was implanted. His GCS was 5/15 and he had bilateral reactive pupil as well as a positive corneal reflex in his left eye. CT scans of his head revealed that his midline shift had improved, and the ventriculostomy catheter tip was discovered to be the correct place in the frontal horn of the right lateral ventricle. The patient was subsequently started on a continuous infusions of 3% natrium chloride. ICP and cerebral perfusion pressures were normal for the first 24 hours with the EVD open at 10 cm. And about the management and nursing care of the patients, day 2, patient ICP was in the upper 20s due to severe hypertension and fever all of which were managed with additional sedation, nicardipine infusions, and target temperature management respectively. Repeat CT demonstrate progressions, cerebral edema with no increasing midline displacement or bleeding. Hospital day 3 GCS improved from 6 to 8 with intake brain stems reflex. Hospital day 4 SpO2 96 dropped to 87, increased in fractions of inspired oxygen from 50% to 80%, and positive and expiratory pressure. Respiratory culture was acquired and a CT X-ray indicates growing Bibacilla opacities, and at figure 7 it will show at appendix. Therefore, he was put on IV Venco on the spot. Hospital day 5 GCS dropped from 8 to 3 due to high ICP. During bronchoscopy, his ICP was found to be significantly raised at 46. Therefore, 23% natrium chloride was supplied intravenously during a 10-minute period. Following that, a second CT of the head was done, which revealed cerebral edema in progressions but no change in midline shift or bleeding. Hospital day 6 respiratory culture indicate methicillin sensitivity, Staphylococcus aureus, and Pseudomonas aeruginosa. A follow-up chest X-ray revealed increased infrared and bilateral feral infusions. Vancomycin was replaced with IV levofloxacin and IV cepheid as an antibiotic. Hospital day 8 improved GCS of 6. During an EV claims experiment, his ICP was regulated and the EVD was subsequently withdrawn. There was also copious amount of thick, tense endotracheal secretions, necessitating another bronchoscopy with saline lavage. And hospital day 14, SpO2 improving and stay constant at 97%. From AVRV to continuous required breathing, the ventilator mode was transient CMV. And then sedation was removed from the patient, GCS 10/15. Therefore, he began taking amanitin. Hospital day 15, GCS of 10/15. A CT scan of his brain revealed that his widespread cerebral edema has improved and has the investments of his basal trends. And hospital day 16, the patient neurological status remained constant, but a repeat chest X-ray indicate an increase in right side infiltrates with clearance of left lung opacity. Hospital day 17, SpO2 maintained at 97% on continuous positive air pressure. And then hospital day 18, the patient experienced tachypnea and was reintroduced to CMV due to piperacillin or Tobacter resistant Pseudomonas. The antibiotic was changed to dazodin to levofloxacin and nebulized tobramazine. And his neurological state remained constant on hospital day 19 and he was stated on Provigil. He was also provided a helmet for protections. The patient neurologic state remained unaltered 2 days later on hospital day 25 and he was released to a long-term care facility. And 3-monthly follow-up visit found that the patient was still living at home with his mother. His tracheostomy and gastronomy tube has been removed in the interval. GCS score was 13. His GOS score 3 on a 5-point scale, indicating significant damage and a lifelong need for assistance with everyday functionings. So he received a 44/8 on walk on a Lawton instrument activity of daily living scale. And then 11 months after the accidents, he had comparable outcome ratings and had developed a seizure problem. Nevertheless, speech treatment helped me helped him significantly improve his speech, and second CT scan of the head revealed that the external herniation had improved. And this was appendix.
So the conclusion is the treatment of the TBI is difficult and it should be evolved in accordance with evidence-based medication. And currently, the primary goals of the treatment is to limit subsequent brain damage with assistance of many specialists in critical care environments. About the prognosis, it's frequently more difficult than the therapy itself, even though certain exam and invasive abnormalities are linked with a bad outcome. These findings are important because they can be used to guide families and loved ones when facing decisions about course of care in this most of case of TBI. That's all my presentations. Thank you.